Welcome to our podcast, Geriatric Cardiology. This is your host, Pratik Doshi. I currently serve as the editor of the JACC monthly newsletter and podcast, where we do deep dives into hot topics in cardiology. I'm very lucky to be joined today by Dr. Daniel Forman, who's the chair of geriatric cardiology at the University of Pittsburgh Medical Center and the VA in Pittsburgh. And he's also the associate director of translational research at the University of Pittsburgh Aging Institute. Dr. Forman is a prolific researcher with over 200 publications centered on aging, cardiovascular disease, exercise testing, and exercise training, and a true pioneer in geriatric cardiology. Dr. Forman, it's such a pleasure to have you on our episode today.
Thank you. It's nice to be invited.
Absolutely. So geriatric cardiology is obviously a big thing. And before we get there, though, we want to learn more about you. Could you give us a one-liner about yourself and maybe things you like to do outside of medicine?
Outside medicine? Well, I would say that I've had kind of a change in life where during COVID I became much more active physically with strength training and aerobic training than I ever have in my life. I kind of am practicing what I preach, and it's kind of changed my whole life. I feel a lot better, and I feel like I embody now the things that I tell my patients.
That's amazing. I will say I've been trying to get into, like the CrossFit and everything, and I am always the worst person in that class. So I'm going to take a page out of your book and try again.
Yeah, well, I was never an athlete as a younger person, so this is great at this phase of my life.
You could have fooled me, so. But we're here to talk about geriatric cardiology, which is, in my opinion, maybe your opinion as well, an underappreciated aspect of cardiology, then a burgeoning field that we probably all need to understand given the burden of cardiovascular disease in this population.
Yeah.
So what is different about managing cardiovascular disease in geriatric patients that most of us may not realize?
Yeah, so I'm going to start with acknowledging the fact that probably most people that listen to this, whether or not they're geriatric cardiologists, take care of older patients. And I think what many people say is, gee, I know I have many older patients and I administer great care. I'm very caring and I'm very well informed. And so why do we need geriatric cardiology? Mm-hmm. But I would say that geriatrics is really a game changer. It profoundly changes the way I think about my patients, because I'm not treating only cardiac disease. I'm treating a patient who's older, who has cardiac disease. So when I think about a stent or a new heart failure medicine in someone who's in their 80s or some part of an aging spectrum, I think about where their health has been lifelong. How old are they really? Is someone who can be 80 and playing tennis and really running around the court, and there's somebody that's 80 and can't even walk across the room. So whether or not that stent or medication is going to work is really profoundly affected by trajectory of aging. And aging itself really has very specific components. When you think about someone who has cardiac disease, they usually have many comorbidities. And it's not just like diabetes is one comorbidity that's integrated into a risk score, but it's 10 or 12 comorbidities. It's their hearing impairment, it's their arthritis, it's the cognitive impairment. And that really will profoundly affect the efficacy of the treatments you want to give. So at the ACC this year, there was a whole session by the top administrators or the top leadership of ACC talking about value of care. Mm-hmm. And for the first time in my career in this space of geriatric cardiology, the implications of aging were truly expressed. That the outcome is not the cardiovascular outcome, it's the independence of the patient, it's the function of the patient. So I would say that aging is profound. And so if someone dismisses age as a number, they're missing the point that aging really affects the outcomes. And the outcomes that are based upon people in their 50s or 40s that have resilience to get better cannot be assumed for someone who's in their 80s. Some may be able to spring back, but many cannot. And the administration of care for someone with cardiovascular disease in the context of aging is really different. It's the same as a pediatric patient. You just can't assume that the drug is going to work for every pediatric patient because they're in transition of their life. And so is an older patient. And I think we need the tools, the sophistication to think about multimorbidity, frailty, polypharmacy. All these geriatric precepts are entirely relevant for cardiovascular outcomes.
I think that's a great point. And something that you keep referring back to is this difference between their numerical age and maybe their, let's say, call it their biologic age, unless there's a different term for it. How do we, when we're sitting down with a patient, how do I determine if a patient, truly is 80 numerically or 80 biologically?
So as I see it, this is a great question, and it's outside the the thought process of most cardiologists who are thinking about the BNP and the ejection fraction or some other cardiovascular metric. And so I usually start with function, where they are with function. I think about comorbidity. I'm doing a cardiac rehab study. We're seeing that almost everyone in cardiac rehab who's over 70 has 11 plus comorbidities. And it's not just diabetes, as I mentioned earlier. It's a spectrum of arthritis and lung disease and GI disease with many different medications. So when I'm thinking of my older patient, the comorbidity, the function, frailty, which we could talk about, is a very hard issue to measure because there's so many different metrics to measure it. But that concept of frailty, diminished resilience to really respond to treatments or disease, very critical components. And the other thing which is worth mentioning, but it's the tip of an iceberg, is the fact that there's a whole new field of geroscience, which is identifying different components that really drive aging. These hallmarks of aging. Aging is not passive. It's a matter of genetic damage. It's a matter of epigenetic changes of how our body works. It's proteostasis. It's the way the mitochondrial work with energetics. It's protein. It's nutrient sensing. There are just so many different components, and this is brand new science. And this is really changing the way I think, and I think all of us for the next decade are going to be completely oriented towards someone's biological age, driven by geroscience, with a whole new concept of gerotherapeutics. I want to acknowledge, like Paul Ritker's focusing on inflammation. That's a gerotherapeutic as I see it. Inflammation is a factor of disease, but also a factor of aging. But there are many other gerotherapeutics, senolytics, and a variety of other factors that are really being recognized as being constitutive to cardiac disease. And I think that those are all issues of aging that we're beginning to recognize.
Yeah, aging has obviously captured not only cardiology's fascination, but also the general public's fascination with it. And it's important for us to really recognize, like you said, that the number is just that, it's a number. And we need to really think about all these other factors if we want to provide comprehensive care. And that applies regardless of whether you're a general cardiologist or you're specialized in your way as a geriatric cardiologist.
Well, if I'm successful, I love my career, and it's become more rewarding as I've gone along in this space, because it's becoming more and more centered. I mean, 10 years ago or 20 years ago, when I was first starting down this path, the geriatric cardiology group was like a small group, like far away from the main tent of the ACC and the AHA meetings. But now we're at center stage, and as I mentioned earlier, we're on the minds of top leadership of the ACC and all the equivalent organizations throughout the world. So I think every cardiologist, and frankly every caregiver, every nutritionist, every physical therapist, exercise physiologist, nurse, we should all be aligned with thinking about aging as a component of care. Absolutely.
And one of those components that I, as an internal medicine resident, and probably our fellows and our cardiologists in general, one of the things that we've noticed is that biomarkers, the ones that we use, such as BNP or troponins, are often just not as predictive of disease in elderly patients as they are in maybe the regular patients that we see.
Yeah.
How do we go about interpreting these types of lab values?
Yeah, it's a great question again, and many people see it as a conundrum. So I want to acknowledge that aging itself really drives changes that overlap with what we think of as abnormal biomarkers. So the first thought that I have is the negative predictive value of biomarkers is still very important. The CACC score, a zero CACC score when you're 80 would argue strongly that there's really very little value that's in most people for being on a statin. So that's a pretty powerful use of a biomarker. But likewise, a negative predictive value of troponins or BNP is still strong. The positive predictive value becomes, a little bit less reliable, and it does lead to the thought process, which is still an ongoing science, as to whether we have age-normalized cut points for positive predictive value. That's a controversial area of research, but without trying to pontificate too much about that, I would say that the spectrum of biomarkers is growing. It overlaps with what I was saying earlier, the geroscience biomarkers. Inflammation is a biomarker, senescence is a biomarker. So I think, so again, understanding the limitations of traditional biomarkers, understanding that there are new biomarkers, and really also understanding that even in present day there are different kinds of biomarkers. I would say that imaging provides biomarkers with CACC scores and psoas muscle size and a variety of other factors that are really very topical. And likewise, thinking about function as a biomarker, knowing, again, I started with the point that I think function is really a critical determinant of someone's ability, how sick they're going to be with their initial disease, and their ability to recover from a procedure or medication. So I think all of these things is biomarkers.
Absolutely.
With a growing sophistication of application.
Absolutely. No, I think you bring up a really good point where we can't limit ourselves to what we think about in terms of traditional biomarkers, and this is a developing field that we all probably have a responsibility to pay attention to.
Yes.
One of the questions that actually came up on rounds this past week was in terms of interventions in the elderly population. Obviously, there's things of, we have to think about frailty and how well a patient is able to tolerate it. But within your experience, when we're thinking about, doing invasive or non-invasive measures for geriatric patients, are there other things that we should be considering while we're making those decisions?
Again, this is the stuff of a lecture and an ongoing body of science. So these decisions, as you're implying, really have to be made quickly. There's an acute intervention. One is I want to recognize that this notion of frailty in the context of cardiovascular disease is sometimes very modifiable. In other words, when someone has critical aortic stenosis and they're functionally impaired and they might be deemed frail, if you restore flow and increase perfusion, sometimes that image of frailty can be very significantly modified. So I think to assume that someone is too frail for intervention, I think is really very problematic. As I see frailty as a physical phenomenon, and I think about it in terms of muscle and a variety of other physiological premises, which in many cases can be modified. So when I think about somebody who needs an acute intervention, I think about what that recovery will entail. I think about cardiac rehab an awful lot. I think about novel ways of administering cardiac rehab to overcome initial frailty and disability, and to really restore, not necessarily MET level. And I think traditionally people have looked at function as just how many minutes can you go on a treadmill and what grade and how many METs. I think of function as ability to stand, ability to live independently, ability to really live your life. So again, I think that's critical when you're thinking about the stent or you're thinking about the new cardiac med. Every cardiac med in many cases is a contribution to polypharmacy and complexity of care, but the trade-off is perhaps better cardiac function, better cardiac output, better vascular function that could improve brain health, improve muscle health, and improve a lot of other elements of physiology that could lead to vitality. So I think it's a balance, and I think for every single caregiver, every point of care should invite that kind of thought process. The one thing which I think is worth also emphasizing is there's this notion of shared decision. We really don't know the best outcomes for our older patients. The whole premise of evidence-based guidelines of care is not based upon an older population. It's really inherently problematic, and it's really a little bit out of balance with what we think of as cardiologists, that we have an evidence-based rationale for everything we do. I would argue we don't have that for older adults. So I feel it's incumbent on me, and I think every provider, to ask your patients what they want, what their goals are. Many people who are smart and sophisticated don't want the care that we think is the right care, and I think they should be respected. I think you can have a dialogue and express your point of view, and I do that with my patients pretty regularly. I really believe in that. It takes time, but I think it's the nicest and best care.
And I think, that was actually one of the questions I wanted to ask you, is that our clinical research and our trials that we base most of cardiovascular medicine on don't include elderly patients, especially ones that probably end up receiving most of these treatments. So what recommendations do you have for those who are either launching or creating or going into this world of clinical trials into how do we make sure we address this population and include them in our studies?
Another $1 million question. And I would argue it's expensive, and I think this is really tricky at any phase of your career, no matter junior or senior, because if you want to do a trial that really captures the range of older adults, it's usually expensive. So I think what you're implying is that I want to emphasize, not all older adults are the same. First, even the word elderly. I mean, many people who, the guy that I mentioned earlier who just played tennis for 3 hours and is 82, would probably be really upset if you called him an elderly man. He's an older adult and he is really fit and robust. So I think the word elderly is pejorative. So it's old, but our population of older adults is skyrocketing. People are living longer, and many of them are very robust. But there's a greater complexity of care because many are not robust. Many are frail. Many are sedentary. And when I say frail, it's body. It's really physiologic. It's body composition, it's brain health, and it's a variety of other really constitutive factors. So I would argue, as a researcher, and this is my career is really based in research, is to capture as many variations of aging as I can. So this involves people who are living long-term care, people who are playing tennis, who are fit and independent, and everything in between. And so that involves great challenges, usually pragmatic research, trying to capture the full spectrum of adults. So this notion of pragmatic research is very topical for an aging population. It includes capturing biomarkers that I've referred to before. That includes body composition that's often very expensive with imaging. It includes geroscience, which is often very expensive with various markers, thinking about mitochondrial function and proteostasis and a variety of factors. So it's not easy, but I would think if you want to study heart failure or you want to study, revascularization or any other thing you want to do, it's important to capture the range of people and the range of relevant endpoints for an aging population. And I think that's really incumbent on us. And I think it's the stuff of the best grants and to show that this is part of really responding to the demographic pressures with best care.
Absolutely. No, I think you bring up so many important and informative points that we really need to pay attention to this population moving forward. Dr. Forman, I really appreciate your time and all of your insights. I think you are working on what's going to really transform cardiology moving forward. So it's great to hear your insight.
Yeah, thank you. Thanks for your nice comments. And I'm really honored to be invited to be part of this and have this kind of visibility. Thank you.
Absolutely. I do have one last question for you before we do end. For those of our listeners that might be interested in geriatric cardiology, is there any resources or any sort of articles or things that you can recommend for us to read and kind of find out more?
Well, one is that the ACC has really been a champion of geriatric cardiology. There is a geriatric cardiology section which is really robust and provides a collegiality. There are many funding opportunities for all people at various phases of their career, but particularly early career. So if you have interest in this as a younger, a person earlier in their training spectrum, know there's a home for you. There's really, I can't exaggerate this. There's a burgeoning literature in geriatric cardiology. Like I feel like I was the inaugural chair of the ACC group, but there's a really huge group of people my age, but people a lot younger who are contributing to this. And I think they're very ambitious people, very smart, and I feel like so if you look up geriatric cardiology, you'll find a huge literature. And if there's any questions, if anyone's not finding things they want, if you email me, I'm at the University of Pittsburgh, I would really open a wide door of insight and opportunity for you to
absolutely. Thank you so much, Dr. Forman. That's great. For our listeners, for more about geriatric cardiology as well as other hot topics in cardiology, please subscribe to the JACC Edge newsletter. This is your host, Pratik Doshi, and we'll catch you next time on the JACC Edge podcast.